Okay, hi you guys. So I wasn't able to meet with you guys to do probably the rest of these lectures. I'll probably try to see if I can meet with you guys this weekend to go over an exam review. So I'm just gonna go ahead and record it, and then hopefully you guys can use this to your advantage. So at least for this lecture, I'm just going to be going over the rest of the respiratory lecture regarding Mandiola stuff. In the next upcoming lectures, I will be doing probably the dysrhythmias and then the hemodynamics. In terms of like the pacemaker and 3 lead, I think she more have hit on that in the third exam, but I'm not sure if she also taught you guys a little bit about it. I think there's only maybe one or two questions she might ask you on that, but she was really heavy on that for us for the third exam, and it seems like she's doing the same thing. So just let me know kind of what she explained, and I'll try to help you guys out by this weekend. And if I don't end up having time to meet, I should. I again will always send out either a practice questions document or a Kahoot, but this semester I kind of opted out for that, so I'm just going to be doing a practice question document or something along the lines of that. So in terms of ARDS, we already went over the first thing. You do need to know the Berlin definition of ARDS. She will ask you about additionally, she will ask you about the PaO2 and FiO2 ratio. So make sure you understand that. That was in our last video, so just make sure you watch that if you needed help with understanding all of that. With the risks, again, just understanding the difference between direct, indirect, direct meaning it's pulmonary focused, indirect meaning it's not. So obviously from sepsis, we know that we get risk factors and complications such as ARDS, DIC, other things that you will be learning about like with septic shock. So really indirect sepsis, that's what causes ARDS, but it's not necessarily pulmonary affected or directly associated with the pulmonary system, right? So yeah, in terms of patho, go ahead and read up on that. But really, I think the only thing she asked us was maybe the stages of ARDS, and I don't even think she asked us on this next exam. I'm pretty sure she asked us on like exam. I want to say the exam before the final, which we thought was pretty random. But still, again, everything's up for fair game in her class, and you need to start understanding a lot of this stuff and keeping it in mind for every single exam. So I wouldn't be surprised if she does ask this, but basically, in terms of the stages of ARDS, so after the first insult or injury occurs, you have the 3 different stages. With the first stage, it basically lasts 1 to 7 days, and then that's where you just have inflammation, the capillary membrane with fluid shifting, decreased O2, decreased compliance, platelets, and then increased work of breathing. So this all makes sense because it's starting off, right? So you're going to have that inflammation, you're going to have that fluid shifting. It's the same exact thing of what we've talked about with sepsis before, right? So even though we're talking about ARDS, remember you're still, most of the time it's going to be associated with sepsis. So I would just think about it similarly, where again, at the first stages, you're going to be having a lot of those things. In the second stage, which is proliferative, that one, well, basically, it's already week 1 to week 3. And this is where the hyaline membrane forms. So basically, you have your proteins and then other debris which accumulate in the alveoli, because again, we're talking about ARDS, a respiratory issue, and then basically it forms this membrane. So at this point, and if you look at the name of the second stage, it basically is talking about it proliferating, right? So basically, you're having more of that debris and more of those proteins accumulate, so that's what creates the membrane. So this is what that specific stage is. As long as you remember like membrane, hyaline membrane, you'll be fine. And then basically this ends up worsening the gas exchange, and then now you have more hypoxemia, right? So again, fibrotic, that's the last stage. That's again further on, week 2 to week 3. This is where fibrosis occurs, so kind of scarring of the lung tissue, more prolonged inflammation, and atelectasis, which is basically now your lungs are collapsing in terms of the tissues. So it makes sense when you think about it. It starts off with the inflammation, it grows, you have more of that debris, you're having worsening, and then eventually by the second and third week, you're just having that scarring and you're having more of that hypoxemia. And right, remember we're talking about the different stages. That's what we're talking about too in terms of the PaO2 and FiO2 ratio, how mild, moderate, severe is the hypoxemia, and that could also be associated with the different stages. She won't ask you like to know which one is specifically for which, but it's just understanding, again, you start off on this stage, then this stage, and this stage. So she could ask that, but I don't think she did, and I think it was like one question on like a different exam, and it wasn't anything too difficult or hard. I think it was just tricky because it was like, it's pretty short. Like you have day 1 to 7, week 1 to 3, week 2 to 3. Like it's still a pretty short amount of time. Manifestations, it makes sense between the early versus late, right? Early, you still have a lot of the difficulty breathing, breathlessness, hypoxemia, increased heart rate, right? You're going to see all of those things that you regularly would see. But then the late stages, right? At this point, it's like severe. It's very increased work of breathing. You're having retractions. You're using accessory muscles. So just think about it at this point. Now it's even worse than the early stages. So that's really, I feel like that kind of makes sense, right? Like you're having cyanosis because now you can't really breathe anymore. Your respiratory distress is getting to the point where you can't really hang on for much longer, right? In terms of diagnostics and labs, it basically kind of follows the same thing with like sepsis and understanding like what would you do for an infection state, right? Because they're associated together. So again, of course, you're going to look at your ABGs so you know what your PaO2 and FiO2 ratio can be because you need the PaO2. And then the CBC, obviously, to see if you're seeing anything with sepsis, with WBCs, um, and like your neutrophils, all those different stuff. Electrolytes, always with fluid shifts. Sputum culture, blood culture, right? Obviously, we're talking about, again, if it's secondary to an infection with sepsis. Albumin, pre-albumin, we're talking about that fluid shifting, right? Especially within those last stages when we're having the fluid balance, the third shifting, the first stage, remember it kind of starts. And then imaging, checks X-ray, CT scan, always the same stuff. I mean, checks X-ray, like you would get that with you're having pneumonia, right? Infiltrates. So it's the same exact stuff here. You're looking at alveolar infiltrates as well, so you're going to get checks X-ray. CT scan, again, so you can see what's going on. The infiltrates should look like ground glass, and then obviously once you get into the severe cases, they're going to basically be like the whole white out when you're looking at the picture. Echocardiogram, again, let's see what's going on with the heart function due to all of like this fluid buildup in your alveoli, the pulmonary edema that results. And then additionally, you're wanting to see if it's more of like a heart issue, remember? So one of the Berlin criteria that number 4, origin of edema, it's not coming from the heart, but it's coming from more of a respiratory issue, right? And then pulmonary function test, same exact stuff, just trying to see how the lungs are doing. And then hemodynamic monitoring, as we'll get into that within the next lecture, but you guys already talked about it, just seeing what's going on with the cardiac output and any blood pressure to see, again, how well is the body being oxygenated overall and perfused. So the goal of treatment, obviously not to make the hypoxemia worsen. So I know we talked about this last time in terms of the vent settings. So again, just knowing that, well, number one, this is mostly caused from sepsis, so you're going to do the bundle, right? Obviously, fluid electrolytes, nutrition, oxygen therapy is probably the biggest thing here too. But these are all kind of straight to the point, I feel like. But in terms of understanding the events, we talked about it last time. So if you're not understanding that, I would watch that video. But basically, remember, we are not really caring about the tidal volume. Just because, again, that's what causes barotrauma. Remember, I talked about barotrauma being like almost as if if your lung is a balloon and then you're going to blow it all up with how much tidal volume you have, and you're putting more volume and volume into the balloon, it's going to pop, right? Then you're going to create a lung injury. So basically, it's the same thing. So what we can do, PEEP, we can keep the lungs open for as long as we can, continuously open, almost like it's a CPAP thing. But again, we're not wanting to worry about the volume. Remember, for the ventilation, we talked about the differences between volume versus pressure, right? So we can do the pressure, but we don't really want to do the volume because of the barotrauma risks, right? So that's where you see the PEEP come in with a low tidal volume. You can read that, and that's where we can also do, if they're not having the worst, if they can still breathe on their own, they're just having difficulty breathing, we could put them on BiPAP, CPAP first, and then move our way up to ventilating them, right? And that's usually what we should do. We shouldn't go straight to intubating because if they're able to breathe on their own, we can do that. And then again, you have the high frequency pressure control, right? Because now we're talking about, we can do pressure, but we can't do volume, right? Because again, volume is what creates the barotrauma risk. So we can do pressure, so that's fine. And then you can also do the inverse IE ratio. Again, we talked about that last time. Basically, you can go ahead and have more oxygenation by inversing the inhalation to expiration ratio for that, okay? So those are the things we went through super quick, but really all you need to know is Berlin criteria, understanding this comes from sepsis, understanding you should not really be putting these people on a high tidal volume or any tidal, like you shouldn't really be touching that at all. Yeah, understanding the risks, and then obviously being able to do that ratio equation from that. Okay, so this is why I was talking about with the ARDS. So for permissive hypercapnia, basically we allow the CO2 to be higher, right? Because again, so CO2 removal requires high ventilation rates and volumes, right? So whenever we're looking at the chart, the chart where you're talking about changing the vet settings, right? For CO2, the answers for that one were, it's that if, let's say, our CO2 was very high, so that means in that case, we're retaining all that CO2, so then you can increase the respiratory rate on the vent, right? So then they can breathe that all out. And you can also increase the tidal volume. But again, for a patient like ARDS, you can't really be doing that. You can only really be doing the respiration rate. You can't be really changing the tidal volume because again, that creates the barotrauma risk. So in this, it's just saying usually if you're wanting to take out the CO2, you're just going to increase the respiratory rate and you're going to increase the tidal volume, right? That's according to what the chart says. But again, in ARDS, pushing more air into the lungs would increase the risk of barotrauma. So really, you could just increase the respiratory rate. But with permissive hypercapnia, what this is saying is that we will permit the patient to have a higher CO2 level because at this point, we care more about the lungs being protected rather than what's going on with the CO2 levels. Because the problem with that is basically if I want to put my patient on a higher tidal volume and they have ARDS, the problem is their lungs are very fragile to begin with. Think about, again, like how we talked about with neonates. Their lungs aren't really formed yet. So at this point, again, with ARDS, your lungs are very fragile. So the problem is that if you were to essentially give them a bunch of tidal volume, you're going to blow their lungs up, they're going to be injured, and then you're just going to create for them to basically be on a vent permanently or not being able to breathe on their own ever. So at this point, we rather just let the CO2 happen because eventually they probably will be able to get off a vent. It might take a while, but at least they're still going to have that function. If you put as much tidal volume as you can give it to them. Sure, they're going to be well oxygenated, but the problem is you're just making it worse for them in the long end because again, they're not breathing on their own. You're just putting more volume in them. You're creating more of that tissue damage and everything there. So again, lung protection, okay, that's fine. However, the problems that we get into this is that now we have the respiratory acidosis, right? So the problem with respiratory acidosis, remember, is that means you're hypoventilating. Technically, you're having CO2 be higher, and now you're basically changing your whole entire body's acid-base balance, right? CO2 and acid, that's for the respiratory system, right? Bicarb for the kidneys, that's more about the metabolics, right? That acid-base balance, so we know that. So obviously, if CO2 is high, then we know that that's a respiratory thing, and CO2 is an acid, so that's where you get the acidosis, right? So we know that. So what do we do for the acidosis in terms of our actual body, in terms of our acid-base balance, how that's looking at? We look at the pH, right? So what can we do to manage the acidosis or to alter, since we're in respiratory acidosis, what can we give to help fix that pH to make it so acidic? So we can give sodium bicarbonate, right? So obviously the other buffer was bicarb, so you can actually give sodium bicarbonate so you can help with that acidity. So are we going to look at the CO2 as our parameter to give sodium bicarbonate, or are we going to look at the pH? So we're going to look at the pH, right? So she will ask you that. You look at the pH. You do not look at the CO2. Again, we're allowing CO2 to be high because we want to protect the lungs from injury with people in cases like ARDS, right? But in terms of giving sodium bicarbonate, we're going to look at the actual pH. So basically what it says, sodium bicarbonate is sometimes used to correct the low pH that results from the high CO2. And it works as a buffer to help neutralize the excess acid, right? So that's how we know how much bicarb to be giving is by basically, you know how like when you're talking about the partially compensated, all of that stuff in an acid-base balance equation, this is basically what we're talking about. We're going to give the bicarb, and their ranges are going to be, who cares if CO2 is out of range, the bicarb is out of range. At the end of the day, all I really care about is my entire body's acid-base balance, and that's by looking at the pH, right? So 7.35 to 7.45. So does that make sense in terms of why you're giving the bicarb to help with that acid-base balance, and you're going to be looking at the pH? So basically, we tolerate a higher CO2 as long as the pH stays within the safe range, right? So what are the complications of giving sodium bicarbonate? So I feel like it kind of makes sense for the first one, hypernatremia, because literally sodium bicarb in the name has sodium, right? So what can we do in terms of giving IV fluids, or what can we do to dilute the sodium? So obviously we can give D5W because that helps dilute the sodium within the blood. So if you're not understanding that, that's just kind of a review about your isotonic, hypotonic, and hypertonic fluids, and that takes like 2 seconds to like just look it up really quickly. But yeah, all you have to remember, and I feel like most of you guys do know this, it's just giving D5W helps to dilute the sodium. For the most part, we'll be talking about different IV fluids this semester with different conditions and diagnoses. Most of the time, it's going to be normal saline. And then if you're seeing that there's a sign of hypernatremia, you're going to give D5W, right? So just keep that in mind. But yeah, anytime hypernatremia and IV fluid, D5W to help dilute it, right? And again, sodium bicarbonate, sodium's in the name. Okay, so hypovolemia is the second complication. So this is basically just because when you're giving in a large amount, now you're having a lot of fluid shifts in the body that leads to hypovolemia. And basically, to kind of explain this further on, you do not need to know this, and this is just me being a little bit extra, because I had to do this for my ICU presentation, and this actually kind of helped me figure out like why it was leading to hypovolemia. So take out the sodium from sodium bicarbonate. So if you just look at the, how we say bicarb, you have HCO3 is the equation, right? So sodium bicarb would be NaHCO3 negative, right? So we're just looking at the bicarb right now. So if you look at HCO3, and then it's getting added to a hydrogen. So I don't know if you guys remember this, but basically, because we don't really talk about the hydrogen and how that implies into the acid-base balance. We have CO2, we have bicarb, and technically we also have hydrogen, and I'm pretty sure it is an acid, whereas obviously bicarb is the base, but basically they add together. So hydrogen's like another thing that we can use for our pH, but bicarb basically adds to hydrogen in our body. That ends up making the equation H2CO3, and that goes to carbonic acid, right? You do not have to know this, but this is just helping me understand like why this happens. And then basically after that, the body will then make CO2 to be exhaled. So that's where we get the CO2 being exhaled from, and that helps to lower our pH technically, but doesn't change the CO2 range. It basically just helps exhale extra CO2, and then basically you end up having another leftover of H2O, so water. So that's where you get the hypovolemia from, because basically it's going to help you excrete all of this extra water. So that's kind of the equation. That's more of the chemistry behind it, and I had to explain it for ICU, but I remember when I was explaining it, I was like, oh, so this is where we get the complication from. So it more has to do with chemistry. So again, you don't have to know that, but I think it does help to kind of understand, oh yeah, hypernatremia, and then she talked about this whole equation that we don't have to know. And then, yeah, it leads to hypovolemia because of all the fluid shiftings that's caused by bicarb, like adding into the body and all that stuff. So again, you don't really have to know that, but I do think that it's helpful to kind of understand the why behind things. So hypernatremia, hypovolemia in terms of giving the bicarb. Okay, so in terms of, again, our CO2 is still going to remain high. So what are some of the physiological effects of having a high CO2? So basically, our CO2 is still going to be high because, again, we care more about the pH being within range. So when the CO2 is high, it doesn't just affect, obviously, the body state of being in an acidotic state. It actually impacts our hearts and lungs. So one thing that you can remember is basically CO2 is a vasoconstrictor in the lungs, and then it's a vasodilator in your systemic circulation. So two of the problems, you're going to have left ventricular depression. So basically, high levels of CO2 impair your systolic function, which basically, remember, is what's in charge of contracting and having your heart's ability to pump the blood, right? Whereas diastolic, that was our relaxation period. So whenever you're weakening the heart, and basically this leads to lower blood pressure and other cardiac issues, right? So basically, if you just remember anatomy, it's the left ventricle, and this is just the blood flow, right? The superior inferior vena cava goes to the right ventricle, so on and so forth. So basically, the left ventricle pumps blood out of the aorta to the rest of the body, right? So this is where we're just seeing there's left ventricular depression here, because again, it's kind of impacting the way that the CO2 is impacting the way the systolic function works in terms of the heart's ability to pump out the blood. So on the other hand, pulmonary vasoconstriction, right? Because I said it's a vasoconstrictor in the lungs. So elevated CO2 basically causes the blood vessels in the lungs to constrict. So now the heart has to work against the lungs, because remember, it goes from the right ventricle, right? And then from that right ventricle, it goes to your pulmonic valve, then it goes to the pulmonary arteries, then it goes to your lungs, right? So basically, this ends up also leading to right ventricular failure, as the right ventricle also has to be pumping blood to be able to get to the lungs. And again, this has to do with AMP, right? So remember, the right side of the heart pumps blood into the lungs through the pulmonary arteries, right? So if you need to review that, you can. But honestly, all you have to remember is, okay, high CO2. The bad things about that, left ventricular depression, and then pulmonary vasoconstriction. Those are the only couple of words, 5 words that you might have to memorize. I don't remember her asking about this, but again, I do think it is helpful to know, because in the future, if you ever decide to work in a critical care setting or anything like this, it's just helpful. And then also, when we start adding some other stuff into the semester in terms of like CO2 or in clinic, I feel like it just, I remember I was thinking one day, I was like, oh yeah, it's a vasoconstrictor in the lungs. So, very helpful, I think, to know that. But again, everything's fair game. You definitely do need to know about the sodium bicarb with the pH thing. You definitely need to know about the hypernatremia being caused because obviously it's sodium bicarb. Give the D5W. And then she didn't ask us about these issues, but again, I I want to say that there was something where it was used in like clinic, but I don't even think she asked about that. But still know it. In terms of sedation and comfort, so this one, it's again, this lecture is going to be kind of fast because I feel like I'm just going over things that I feel like she's going to ask you about. Um, so sedation versus comfort, you're going to sedate, then you're going to paralyze them. It makes no sense to be paralyzing a patient and then be sedating them. Think about it like the horror movies where people are literally paralyzed, but they're still there. They're still there mentally. You still know exactly everything that's going around you, but imagine you're just kind of like frozen in your spot. You can't even move. So obviously you want to be able to sedate them first to make them comfortable, and that just makes more sense, right? So, basically, another reason why we sedate and why we paralyze the patients. Whenever a patient is overworking their body to they're just overworking their body so much that their increased work of breathing, their heart is going crazy, every single thing like that. We talked about this a little bit with like the left and right side, with the oxyhemoglobin curve, right? Whenever you're having that oxygenation like demand, you want to make sure that you're lowering that for the patient because eventually the patient will give out. You will give out. Your body will physically get out. So the thing that you can do is obviously sedate and paralyze them, so that they're not overworking. Obviously, if you have the 80-year-old grandma and she's breathing at like 50 respirations per minute, and she's still standing very low, we should probably consider, it's time to maybe put her on a vent or something because I mean, hello, she's overworking and eventually your body will get tired. And also you're creating a lot of lung injuries by overworking your lungs and doing all of that. So the better thing to do is also decrease the oxygen demand, and that causes your body to overall like not be working as hard because keep in mind, if you're not breathing as well, then your organs aren't being perfused, and now your heart's having to overwork, and it's your heart rate's going to be super elevated because it's trying to perfuse the rest of your body by getting all of this blood and all of this oxygen to your organs. So of course it's going to increase because your body is not breathing enough anyways. So do you see what I mean here? So it's just easier to do some of these things sometimes because again, in the long end, we want to make sure that these patients are being able to not have their body be overworking. And again, you're just lowering their consumption and oxygen demand overall. So, yeah, you reduce their metabolic rate, basically, is what we're talking about. So basically, I don't need to. She never asked us about this. I don't think she would. This is more of a clinic thing. I know Logan's class. I think she might hit on this more, but she has specific things to that. Basically, sedation scales, Ross scale. You will be using that in clinic if you're not in ICU already. This basically just helps you tell what the sedation scale of your patient is. I think she might have asked this on like a quiz or something, but I don't even think she asked us about this at all. Pain scales, it's the same scales that we've always used, right? Numeric scales, the faces scales more with children. That's just the pictures one, the flax scale. Again, also with children, observation. CPOT is more of the one that we kind of harp on in clinic, and I think she would more of ask in a, I guess, educational or testing setting. Just because, again, this is the one that we use more of, and this is just helping to assess pain in nonverbal critically ill adults, and most of the time your patients are going to be vented in an ICU setting. CPOT is usually the one that we're getting for that. Okay, so moving on to neuromuscular blockade, the goal is to get basically complete chemical paralysis, right? So it makes sense. It's literally saying muscular blockade, so you're blocking the muscles from being able to move, and now you're having paralysis, right? So the action, it blocks the synaptic transmission at the neuromuscular junction. So remember when we were talking about like the GBS, MS, all like within last semester in third, at the end of the year, which I hate that they put that all at the end. But basically, that's basically what's going on, but we're blocking acetylcholine from being able to go onto the receptor at the neuromuscular junction. So yeah, you're creating paralysis because it's not able to contract because the acetylcholine's not going on that receptor site. So again, you don't really to remember that. All you have to know is neuromuscular blockade means that it's not it's creating paralysis, right? So what do we indicate this for, or who do we do this for? So again, if you need to be intubated, it makes sense to paralyze them, right? Because the problem is that obviously I don't want to be intubated when I'm not paralyzed, because you still have muscles, your lungs are still a muscle, your heart's still a muscle. So we need that to be easy for the doctor and physician to be able to easily intubate the patient and put that in their um, airway, right? And then obviously keep in mind too, if I wasn't paralyzed, you put a tube down my throat, I'm not going to be happy about that. I'm going to want to pull it out, right? So you're basically going to do paralysis for that, give that neuromuscular blockade. You're going to facilitate tolerance of mechanical ventilation. That's another indication, obviously, because again, we're going to be intubating them. Improving oxygenation, that basically means also improving the metabolic rate and everything that's going on there. Same thing with managed shivering. It's the same exact thing, right? Mandela harps on this. If you're shivering a lot, you're basically increasing your metabolic rate, because basically your body just wants to be in homeostasis because your temperature is either too low, too high, all of those things, right? So that makes sense why we give these things. So really the medication, what you need to know for this, it's just this medication, it's acetylcholine, that just sucks, right? So basically it's a depolarizing neuromuscular blocking agent. So the difference, you don't have to know this, but again, I like to harp on every single like little small thing, and I feel like it helped to kind of understand a lot of the stuff that she asks. What's the difference between like depolarizing versus non-polarizing? Well, depolarizing just basically means there's an initial contraction. So I'm trying to think of another med. I guess Reconium or Vercuronium. That's this med that Redonda Vaught used on the patient, who she ended up killing, I think, because it was a medication mistake, I think. So remember that case. So basically, that agent, that medication was a non-polarizing neuromuscular blocking agent. So that one doesn't have an initial contraction. That one is straight up just paralysis. Whereas with this one, it is paralysis as well, but there is an initial contraction whenever you do give this med. It is a shorter duration of life, so whereas the other one, it's a longer duration of life. So really, we use this one and depolarizing neuromuscular blocking agents for short term, like when we need to intubate somebody immediately. You're not going to be using the other one because that one's more long term. And basically, both neuromuscular blocking agents, yeah, they go into those different categories of depolarization or depolarizing versus the not one. And basically, what that means is they both block um, the acetylcholine from going on the receptor sites at the neuromuscular junction. But the difference is that with the depolarizing, it like activates the acetylcholine. So there is like an initial like contraction at first, and then they paralyze. You don't have to know that, but I do think it is helpful understanding neuromuscular blocking agents. There's two different types. One of them shorter, one of them is longer. One of them has the contraction, the other one doesn't. But that explains also why that we use this one for short-term intubation only, and not the other ones. So obviously this one's kind of, I feel like obvious, and this is 100% she will ask you this. And I wouldn't doubt Logan would ask you this either. You need to have an advanced airway in place because literally you're giving a paralysis medication. So the lungs are a muscle, your diaphragm's a muscle, your heart. If you do not have an advanced airway in place and you're giving a paralytic agent, you will be killing the patient, right? So again, you want to make sure that they're on a proper vent setting for that. Your RT is going to be in there. If you're having a patient who needs to be intubated, you're going to have a whole team in there. And we've seen it before in ICU. I saw it before when I was in school. I think it was one of the last weeks, and I was my patient, and I was with her like the entire morning, and then eventually she had to get intubated. So we got to watch the doctor do that, the kind of team with that, and obviously that medication they gave sucks. They said, okay, pushing sucks, immediately was paralyzed. Like literally, you just can see them go limp and everything. Okay, so obviously, the only things that you really have to know with this is the contraindications. Again, read through all of this so you know if you're able to point it out. But really, again, no airway in place. You want to make sure and assess the patient beforehand. Do they have a history of malignant hyperthermia? Because it has been known with this medication, and then myopathies associated with CK, CPK, and potassium. So basically, muscle breakdown diseases, right? Because they can cause disorders with that. So that's all you really have to know because, yeah, it causes increased potassium, rhabdomyolysis, malignant hyperthermia. Those are the big things with that. But yeah, I think it's just more about the advanced airway in place. Okay, in terms of nerves, so a peripheral nerve stimulator, you 100% have to know this. And it might just be like writing it down a couple of times. So train of fours, basically this refers to the 4 electrical stimuli delivered to a peripheral nerve over 2 seconds. So you have the 2 different ones. You have an ulnar nerve and then a facial nerve is the ones that we use, right? So the ulnar one is more of a recommended site, and that makes sense. You don't want to just start with their face first. You'd rather just do the ulnar, right, in the hand. So you have 2 different leads and 2 different wires. One of them's positive, one of them's negative. The positive one is red, the negative one is black. So I just think about it like black is more of a neutral color, neutral, negative. So that's kind of how I think about it. That one's distal. So basically for the ulnar, right, we know that the ulnar, so I obviously radial, right, where your thumb is lining up, ulnar, that's more of like your pinky here. So basically negative is going to be the black wire, that's going to be more distal, and then the red one is going to be more proximal. So if you look at this, this is basically what it looks like. Do you see how the black one is more distal and then the red one is more proximal, right? So distal meaning further away, proximal meaning closer to um, that. So basically, again, the neutral one, that's the one that doesn't really have the color. That's black, so that's negative. The other one, red, positive, right? So basically what you're looking at is for the thumb to be twitching, right? That makes sense because again, the ulnar, the thumb nerve, I would just think about this right there, the thumb. So, and yeah, I would just think like what I used to think is thumbs up for the ulnar, right? And then the other one is the facial nerve. So again, you're going to have the positive red wire. That's going to be located on the outward outer canthus of your eye. So like right out here. And then the negative black electrode is going to be just kind of right below it. It says 2 centimeters below. And again, negative black, neutral, negative. And again, you want the eyebrow to be twitching for this one. So again, it's on your face. So I would just think about it more of like you want your eyebrow. And that's what it is right there. So the positive one, again, that one's the red one, negative, that one's the black one. So that's what you see right there. Um, what do we want in terms of a response for that? You want 2 to 4 twitches total. If it's more than 4, you're not having enough of the blockade. You might have to give more. And whereas if you're having 0 twitches, that means you gave way too much. You're having a complete blockade. So you want to just be able to monitor that for sure. So we want 2 to 4, and she will ask you about that. We want 2 to 4 for that. So you're going to replace electrodes every 24 hours and as needed. Do not place them over broken, wet, greasy, or hairy skin. I think we all know that. Turn the stimulator off between uses. You're going to put them on DVT prophylaxis, such as SCDs, repositioning them, range of motion, oral care, urinary catheters, peptic ulcer prevention. You guys know all of those things. And then the other thing that we have to kind of monitor for problems, obviously same thing with skin integrity, electrolyte problems, nerve injuries that they might have. And then same things with other neuromuscular deviations. If they have Botox, they're not going to be able to obviously have some of those twitches. So those are good questions to ask before and kind of understanding some of their medical history with myasthenia gravis, Bell's palsy, all of those things where they might not have the ability to be able to twitch in the first place or have those responses, right? Prone positioning, this is basically something else that we can do to help oxygenation or alveolar recruitment. So basically 12 to 14 hours, basically after they're 12 to 14 hours prone, you can redraw to look at their PaO2. So this basically, again, the benefit, alveolar recruitment, basically with the way that the anatomy works out for us, basically the weight of the heart and abdomen is off of the lungs if you're in the prone position. I think this is why a lot of us actually go to sleep in this position sometimes too. And then additionally, the pressure in your lower lung fields and on the back are just taken off. So then the alveoli have better and more room for gas exchange. And I think I go to this position a lot because I definitely am a snorer when I sleep. And like I have to I am a snorer with my mouth open. Like I definitely need to be put on like BiPAP, CPAP, something when I'm sleeping. But sometimes I feel like this is just a comfortable position. Just because apparently anatomy says that, and research says that this just allows for there to be more gas exchange, so you can do this. However, the complications is obviously your patient is ventilated. You cannot be really doing this because they are ventilated. They have an airway, right? So loss of an airway, obviously, also same thing. If your kid's very young, no, because obviously you have babies, SIDS, all of those things with, being able to choke, not being able to breathe on their own, everything like that, right? So those are just some things. And then really, you guys can read about this. It's just highlighting on some stuff, but basically it's just taking care of it. She won't even ask, I don't think, any of those things. The last two things I'm going to harp on is probably just sedation versus pain meds. Sedation, benzos, right? So if you're sedating them, you can give them. So we talked about the SUX, that's the neuromuscular blockade agent, right? So that one's the short term. That one has the contraction, so it's depolarizing. Um, so basically, benzos, that's what you give to sedate them. Obviously, you've seen some of these meds before when you're talking about, like with Keppra, if you're talking about these medications, because you also can use them in like epilepsy or seizures. But basically, for sedation, they end in the AMS. So if you forget benzos, they end in the AMS. She will not ask you other ones. She will just ask you these ones, but they end in the AMS. The benzo reversal agent, so the antidote is flumenazole. You 100% need to know that for both classes. And then the other sedatives, propofol, all of those other ones, you don't. She won't ask you about that. I don't think she will, but you do need to kind of know some of those meds because you should be asking or knowing or seeing some of these things in clinic. But again, she literally will just ask about the benzos and then what's the reversal for that. In terms of pain, you guys already know opiates, fentanyl, hydromorphone, morphine. What are we giving reversal? We all know Narcan, naloxone, right? So in terms of the pre, intra, and post, just go ahead and read up on that. She never asked us anything really about this. I just knew, okay, NPO minimum of 8 hours before. Always have informed consent. Obviously, when they're during, you're doing the counts of the equipment in terms of your train of fours. You continue to document everything. And then obviously after, you shouldn't be driving. You should be checking on all these different things. And then basically, if you want to read about what's the difference between like a medically induced coma and therapeutic process, you can read about that. And I feel like it explains this really well. But really, I think the only other thing you have to know with this section, Q4 and PRN for eye lubrication. She hits on this a lot, but it has to be both Q4 hours and PRN. I swear I forgot about this and I don't have it here on the study guide because I forgot. And she mentioned it like 2 times and I was like, yep, you're right on that. I'm going to give that. Yep, that was definitely my mistake. So remember Q4 and PRN. She says Q4 PRN. That's not correct because that means you're going to give it as needed, but every 4 hours, right? It needs to be every 4 hours and as needed. So make sure you're doing that for the eye lubrication for at least whenever your patient is being ventilated, or if they're paralyzed, sedated, whatever it is. If their eyes are open, you can go ahead and give them the eye lubrication for that. Because she says it's super uncomfortable, and I would agree with that. But other than that, that's pretty much it for that section. I'll do another video either tomorrow, probably going over either hemodynamics and dysrhythmias, probably both. And I'll try to upload this as soon as I can. But yeah, thank you guys so much.